Good morning. We are in Brazil, in Rio de Janeiro. Here is 8 a.m. And I know that in China it's 7 p.m. And I would like to thank the China Cancer Association and the World Association for the Integrative Oncology for the opportunity to hold this meeting with the National Academy of Medicine. 1 year ago, we signed a scientific cooperation agreement that has been very fruitful, fostering an intensive exchange of experience. And now I would like to introduce Professor Wang. Wang. She is the Vice President of China Anti-Cancer Association. She is General Secretary of the Asian Oncology Society, General Secretary of the World Association for Integrative Oncology, and she is my partner as moderator of this meeting. And I also would like to introduce the president of the Brazilian Academy of Medicine, Professor Eliete Bouskela. She is academician of the National Academy. She's member of the Brazilian Academy of Science. She's member of the French Academy of Medicine and full professor of Rio de Janeiro State University, among many others qualifications in her career. And then I would like to thank also Professor Eliete for all the support for this integration and this agreement that we have signed with China last year. And then I send now the words to Professor Wang that will say a few words before Professor Eliete has the word. Please, Professor Wang.
Okay. Thank you, Professor Costa. So distinguished guests, online participants, ladies and gentlemen, good morning and good evening. Before I begin, I would like to introduce Professor Maurício Costa. He is the member of Brazil National Academy of Medicine, honorary member of France National Academy of Surgery, and the board of director of Waio. So I would like to express my deepest gratitude to Professor Costa for his gracious moderation. Last year, when I visited Brazil, and we also visited the Brazil Academy of Medicine, and we have signed the MOU, and this time we draw CACA and Brazil Academy of Medicine jointly host the Cancer Summit. So I'm so pleased to work together with Professor Costa and alongside with Professor Costa to chair this session, to chair this summit. Thank you, Professor Costa. Professor Costa.
Professor Eliete.
Yeah.
Professor Eliete, please.
Good morning to the Brazilian participants and good evening to our Chinese participants. I am extremely pleased to have Professor Maurício Costa, Magalhães Costa, that has organized this meeting, because I think we are having a time now that cooperation should increase among scientists and among countries. So every time that this is not the case, it's really a pity, because I think scientists could, as much as possible, go out of their ivory tower to reach others and to exchange ideas and projects. So I am extremely happy that our project with CACA that has started last year, it's going stronger and stronger, because cancer is one of the major diseases that we have to fight now. And I am sure that Professor Daiming and Professor Wang will help us in learning more about this disease. So I think that we have a lot to profit from this interaction. And Brazil and China have a lot of opportunities to join efforts and to work together with more research and more exchange to improve the science on both sides. So it's a very good and very important happening for us today. And I would like to congratulate Professor Wang and Professor Daiming for spending the time with us during this meeting. Thank you very much. And I am sorry to inform that in 1 hour, more or less, I have to leave because I have another commitment about research as well. But I will be here as much as possible. And again, thank you very much for having this cooperation to go on. Thank you.
Okay. Thank you, Professor Eliete Bouskela, for your inspiring opening remarks. Your leadership sets the tone for what promises to be transformative dialogue. So now it's my great honor to welcome Professor Daiming, President of CACA, President of Waio, and International Corresponding Member of Brazil National Academy of Medicine, to give his opening remarks. Professor Fine, please.
Thank you, Dr. Wang and Dr. Costa. Distinguished guests, ladies and gentlemen, good morning and good evening. It is my great honor to deliver the opening remarks at this summit. Firstly, on behalf of China Anti-Cancer Association, CACA, and also the World Association for Integrative Oncology, I would like to extend my sincere gratitude to Professor Maurício, Costa, and Professor Eliete Bouskela, the president of the Brazil National Academy of Medicine, for their visionary leadership and tireless efforts in initiating and co-hosting this landmark event. CACA and ANM share a long-standing commitment to advancing global medical sciences. With the 196 years of industrial history, ANM has achieved remarkable milestones in shaping the world's medical landscape. Similarly, CACA, as China's largest anti-cancer organization with over 150,000 members, has been at the forefront of cancer control, hosting hundreds of academic exchanges annually across the nation. Over the past 2 years, our collaboration with ANM has flourished, spanning academic exchanges, joint conferences, experts visits, and talent development. In July 2024, the two organizations formalized this partnership by signing the MOU agreement in Russia, followed by the highly successful inaugural symposium. Today, I was honored, this May, I was honored as international corresponding member of ANM, and a pleasure to further strengthen our alliance. Cancer continues to be a challenge for both China and Brazil. This summit reflects our shared commitment to advancing research, accelerating knowledge, the sharing, and improving outcomes for patients worldwide. May this gathering be another mark of a strong and lasting partnership between our two nations. Let us work together to turn hope into action. I wish the 2025 China-Brazil Anti-Cancer Summit in resounding success. Thank you. Thank you very much.
Okay. Thank you, Professor Fang. As mentioned, CACA and ANM have made great progress in strengthening our collaborations in the past 2 years. Now let's transition to today's keynote presentations. This session will offer us insightful perspectives and groundbreaking research findings from invited speakers. Professor Costa, please go ahead and introduce our first speaker, please.
Yes, our first speaker is Professor Maria del Pilar Esteves Diz. She is Director of Cancer Institute of the University of São Paulo. She's Associate Professor of also in oncology in the medical school of the São Paulo University. That's the biggest one in the country. And also she's very involved with research in the DOR Institute. It's really a great pleasure. The ICESP, this Cancer Institute in São Paulo, it's an outstanding institution. And I have discussed with Professor Paulo Hoff, that's the chair of the Institute, to be more close and cooperating with CACA in the future. Her presentation will be dynamic evaluation of ctDNA in patients with HPV-related cervical and anal cancer for adjuvant treatment with immunotherapy. Professor Pilar, thank you very much for your participation. The floor is yours.
Thank you. Yes, good morning for Brazilian people. Good evening for Chinese people. I'd like to thank the invitation. It's a pleasure. It's an honor to be here to present one of our studies related to cervical cancer. It's a very huge problem in Brazil, and the public services don't have enough budget to introduce immunotherapy for every patient. That we are trying to find a more specific and cheaper way to treat these patients. I will share my presentation. Just a minute, please. Can you see the presentation?
Let's see your presentation. The slide. We cannot see your slide.
I cannot. I try again. Sorry. Yes. Can you see now?
Yeah, that's good. Now.
Okay. No?
Yes.
Yes?
Yes, we can see.
Yes.
We can see.
Okay, let's go.
Done.
I think
Just right now we can see, but now, no.
Yes.
Okay, Now it's okay.
Thank you. Sorry. Okay. Thank you very much for the kind words. This is the ANA trial, a dynamic evaluation of ctDNA in patients with HPV-related cervical and anal cancer for adjuvant treatment with immunotherapy. We aim with this trial to the development of a low-cost, locally produced HPV ctDNA accessible to the Brazilian Health Unified System, the comparison of the local ctDNA test with commercially available tests, the assessment of ctDNA accuracy compared to imaging methods for follow-up, the evaluation of immunotherapy efficacy in patients with positive ctDNA, and the investigation of the impact of PD-L1 expression levels at HPV genotype on the therapeutic response to immunotherapy. We'd like to improve follow-up methods for HPV-related neoplasms and develop this low-cost ctDNA test focused on HPV ctDNA and evaluate the immunotherapy. If immunotherapy really improves outcomes in ctDNA positive patients, we'd like to, we suppose that ctDNA positive patients at the end of chemoradiotherapy are the best candidates to use immunotherapy as adjuvant treatment. In secondary objectives, we'd like to compare the accuracy of the standard ctDNA with the HPV target ctDNA, the performance of the local test with the commercial assay, investigate the influence of PD-L1 and HPV type on immunotherapy response, the efficacy, assess the efficacy of immunotherapy in ctDNA positive patients, and evaluate the cost effectiveness of ctDNA for post-treatment surveillance. The HPV is responsible for approximately 70% of anal cancers and over 90% of cervical cancers. In Brazil, cervical cancer is the third most common cancer and the third leading cause of cancer-related death among women. Most cases are diagnosed at a locally advanced stage, requiring treatment with chemoradiotherapy. And up to 40% of cases experience recurrence, highlighting the need for improved follow-up strategies. The imaging methods are often inconclusive in the follow-up of these patients. We need multiple invasive biopsies after during this follow-up, and this provides to us a high cost of surveillance and repeated exposure to radiation. We have almost 1,700 new cases of cervical cancer every year in our country, and about 40% are advanced stages. The ctDNA assessments has several advantages. It may enable detection of minimal residual disease before it becomes radiologically detectable. And we have the evidence that patients with positive ctDNA after treatment have almost 13-fold higher risk of recurrence. The regular monitoring may reduce the need for invasive procedures, and it has the potential to personalize oncological follow-up and guide therapeutic intensification. But this is a very high cost test, and we are working on the local development of an HPV target detection method. This may turn this strategy in a very cost-effective strategy for public health system. We know that the sensitivity and the specificity of ctDNA is much higher than biopsy and radiological tests for residual disease. And the immunotherapy plays a very important role in the treatment for patients with HPV-related cancers. It enhances immune recognition and the eradication of HPV-associated tumor cells, establish His role is really well established in metastatic settings with demonstrated survival benefit. And recently, we have established the role even in a more advanced disease in the adjuvant scenario. Post-treatment positive ctDNA may identify candidates for adjuvant immunotherapy. Biomarker-driven selection optimizes treatment efficacy and cost effectiveness, and ongoing trials indicates potential benefit of immunotherapy after chemoradiotherapy in high-risk patients. We have the Keynote, the results from Keynote really pointing to us this way. We presented last year at ASCO the results of 33 cervical cancer and anal cancer patients treated with definitive chemoradiotherapy. ctDNA positivity after treatment leads to a high risk of disease progression. The PFS was 8.2 months for patients that were the progression-free survival, or 8.2 months for patients who were ctDNA positive versus not reached in patients that were ctDNA negative, with a higher hazard ratio of 17.5 and a very significant p-value. Showing to with this data, we made the hypothesis that these patients with ctDNA positive needs adjuvant treatment, and patients with ctDNA negative results after chemoradiotherapy maybe do not need the adjuvant treatment with immunotherapy. The inclusion criteria were histological diagnosis of anal cancer or cervical cancer. Patients needs to be HPV positive. They have localized or advanced localized disease, stage 1, 2, 3 for anal carcinoma, and stage 1B2 to 4A for cervical carcinoma, according to IJCC 8th edition. Indication of definitive treatment with radiotherapy, with or without concurrent chemotherapy, a good performance status, I call 0 or 1, more than 18-year-olds, and we may include HPV positive patients if the CD4 count is greater than or equal to 200. And of course, absence of clinical comorbidities that could compromise the participant's safety. Exclusion criteria were patients with distant metastasis, patients that progressed during or immediately after finishing the chemoradiotherapy, requirement of very frequent blood transfusions, for example, on weekly basis, life-threatening disease, a personal history of other active malignancy, pregnant human, and active or opportunistic infection or disease. The trial design has two phases. The first phase is the validation phase. Patients with cervical and anal carcinoma are candidates at the end of that are candidates to chemoradiotherapy, and we selected only the first procedure is to look at tumor HPV. If patients are tumor HPV negative, they are discontinued, but who really may take part of the trial are patients with tumor HPV positive by PCR. Then patients has the first evaluation of ctDNA and HPV DNA assessment. Patients go to definitive chemoradiotherapy during 8 to 12 weeks after that. We have the new ctDNA and HPV DNA assessment. ctDNA. patients with negative DNA will be followed up with regular assessments, and patients with positive ctDNA will be invited to the validation phase, the invitation phase 2, the interventional phase, where patients will receive pembrolizumab for 1 year. Patients with negative ctDNA will be followed up and with ctDNA and HPV DNA assessment until 11 months. The primary endpoints, I've already told some of them, but in the validation phase, the sensitivity and specificity of the HPV ctDNA test compared to commercial ctDNA assays and routine imaging. And for the interventional phase, the 6-month progression rate in patients with positive ctDNA treated with immunotherapy. The secondary endpoints were the positivity rate of post-treatment of ctDNA, correlation between these two markers, the clearance rate at 6 and 12 months after immunotherapy, the 1-year recurrence in ctDNA HPV ctDNA positive patients receiving adjuvant immunotherapy, the progression-free survival and overall survival of these patients with monotherapy, the recurrence rate in negative patients, a recurrence comparison between patients with sustained negative and converted positive ctDNA during follow-up, the PD-L1 expression profile and potential correlation with the response, and HPV subtype distribution and association with outcomes. This is a very the schema. The patients have 1, 2, 3, 4, 5, 6 assessments of ctDNA and HPV DNA assessment before the treatment with chemoradiotherapy, 8 to 12 weeks after chemoradiotherapy with 6 months, 9 months, 12 months, and 8 months. And radiological assessment were performed simultaneously in all these blood samples, and on these dates where we have the blood samples. The post-treatment surveillance which HPV-related malignancies will be done according to our current standards, following radiochemotherapy with clinical visits, physical examination, and imaging. We perform chest and abdominal CT scans and pelvic MRI at these points that are related before. Sorry. And for patients with negative ctDNA, we will perform several assessments. And positive ctDNA during follow-up, the patients will have the discontinuation of scheduled sample collection. And additional collections after 8 months will be performed at discretion of the investigative committee. Patients with positive ctDNA will be invited to receive immunotherapy up to 1 year or until progression or limited to toxicity. Of course, we have the medical consultations, the assessments, and the radiological assessment every 3 months. At the interventional phase, we are doing the immunotherapy with PD-1, pembrolizumab, 200 milligrams every 3 weeks. We are doing just 1 year of treatment, and we have per cycle monitoring with vital signs, clinical visits, physical examination, complete blood count, and serum biochemistries. The radiological assessment is done according to our local guidelines with every 3 weeks during treatment, and all the analyses are performed by RECIST criteria 1.1. Here, We enrolled 16 patients at this until now, 12 patients with cervical carcinoma. We had one screen failure due to insufficient tumor sample for HPV analysis. 100% of our patients were HPV positive. 4 patients were HPV 16, 4 HPV 18, 1 HPV 39, 1 31, and 1 HPV 45. 6 are still undergoing chemoradiotherapy. 5 are waiting for response, evaluation, and new ctDNA assessment after chemoradiotherapy. 4 patients with canal carcinoma patients were included. 2 of them are HIV positive, and all patients were HPV positive too. 1 co-infection with HPV 16 and 43, 2 HPV 16, and 1 HPV 59. This points to us that's very important to look for all high-risk HPV in our patients. Of course, the 16 and 18 are the most important, but we have all this high-risk HPV in our population. All of these patients had positive ctDNA at baseline, showing to us that the high sensitivity and specificity of the ctDNA for patients with active disease. 2 of these patients are undergoing chemoradiotherapy, and 2 are waiting for response evaluation and new ctDNA assessment after chemoradiotherapy. I forgot to say, but we expect to include 112 patients to this study. Thank you very much.
Please, Costa, please. Professor Costa.
Yes, thank you very much, Professor Pilar, for the outstanding presentation. Very interesting and important study for our country. And now I ask Professor Wang to present the keynote of the next speaker, please.
Okay. Please join me in welcoming our second speaker, Professor Ma Jun. Professor Ma is the academician of Chinese Academy of Sciences, Executive Vice President of Sun University Cancer Center, and the Chairman of a CACA Nasopharyngeal Cancer Committee. His presentation topic is enhancing efficacy and reducing toxicity, therapeutic optimization in nasopharyngeal carcinoma. Professor Ma, please.
Yes, and please, I cannot share my PPT, so Professor Maria, you withdraw your PPT. Yes. Can be seen.
Okay, that's it.
Yeah, it's okay.
Yes, very good.
Yes, okay. So hello everyone. So it's a great honor to be here to give the recent progress in treatment of nasopharyngeal carcinoma with a focus on improving efficiency and while reducing the toxicity. So NPC arises from the epithelial lining of the nasopharynx and is located near vertical structure such as the skull base and the cranial nerve, leading to the frequent intracranial invasion and the nerve involvement. It also frequently spread to cervical lymph nodes and distant organs like the bone and liver. So NPC is endemic to China with approximately 42% of the global cases. For example, at our cancer center, Xinjiang University Cancer Center, we treat over 7,000 new diagnosis cases last year, making us the highest volume center for NPC worldwide. The extensive clinical and research experience has earned the SUSY the #1 global ranking for NPC on ExpertScape. During the anatomic location near the vital structure, NPC is not suitable for surgery. Fortunately, more than 95% of cases are non-characterizing carcinoma that respond well to radiation, making radiotherapy is the treatment cornerstone. Now, in my talk, the first part I will focus on our work in advancing system therapies to enhance efficiency. While radiotherapy has significantly improved the local control, distant metastasis still accounts for 80% of NPC-related deaths, underscoring the need of the effective systemic therapy. Back in 1998, the NCCN guideline recommended adjuvant cisplatin plus 5-fluorouracil chemotherapy following radiotherapy for stage 2 to 4 disease. However, our prospective studies show that adjuvant PF didn't improve survival and cause severe toxicity in about 42% of patients. This leads us to question, when should chemotherapy be given and what are the optimal regimes? Our studies identify that the gemcitabine plus cisplatin regime access both microenvironment and cytotoxic. Cisplatin and gemcitabine target different stages of DNA damage and repair. Through the single cell sequencing, we observed an increase in ICOS positive innate like B cell and the tertiary lymphoid-like structures after chemotherapy, especially in gold responders. Mechanistically, we found that the GP chemotherapy activates ICOS positive B cell, which in turn promote CD4 positive T cell differentiation, leading to the formation of the tertiary lympho-like structures and enhance infected T cell responses. At the same time, we observed that the DNA damage in tumor cell activates the C-gas sting pathway, which boosts the tumor antigen presentation. This work was published in Nature Medicine. But does it translate clinically? We conducted a prospective trial evaluating GP as induction chemotherapy before radiotherapy. Results show an 80.8% improved in 3-year, 4-year-free survival with a grade 4 toxicity rate of just 5%, demonstrating both higher efficiency and lower toxicity. The trial, widely recognized and published in the New England Journal of Medicine, the GP gym is now included as a level 1 recommendation in Chinese, American, and European guidelines, become the global standard of local regionally advanced MPC. However, around 20% of the patients still experience treatment failure despite standard care. Our research revealed that recurrent and metastatic lesions often originate from the mineral residue tumors. We identified a subgroup of the PRO-positive stem cells that gave rise to macrometastasis and showed the resistance to the conventional high-dose chemotherapy administered every 3 weeks. We explore metronometric chemotherapy, that lower dose treatment given continuously as the strategy to suppress the tumor stem cells. In our phase 3 trial, metronomic typing improved 3-year FFS by 9.6% and reduced severe adverse events by 25% in high-risk patients, achieving both strong efficiency and good tolerability. The study was published in The Lancet and has since been incorporated into the NCCN guideline. Historically, MPC was called as the lymphoepithelium due to its origin in the Wilder's ring and its dense lymphocytic infiltration. However, our research shows that despite abundant T-cell infiltration, most of these cells are functionally suppressed. They express high levels of exhaustion markers such as PD-CD1, LAG3, and PD-L1. These findings suggest the potential benefit of the PD-1 therapy. We conducted a prospective trial integrating the PD-1 blockade ctDNA throughout the full course of the chemoradiotherapy. This approach reduced the failure risk by 42% and improved the 3-year event-free survival by 10% with manageable toxicity. Another study, we used adjuvant PD-1 blockade carrizolimab post-radiotherapy. The outcome was similar to the full course of the PD-1 therapy, but with even fewer side effects. Both studies were published in the top-tier journals, The Lancet and JAMA. Standard treatment of MPC include 6 cycles of cisplatin, which already approaches the up dose limited. 3 of these are given concurrently with radiotherapy, often causing severe acute toxicity such as mucositis, weight loss, and the long-term effects such as renal impairment and hearing loss. With PD-1 immunotherapy enhancing in treatment efficiency, we began to ask, can we safely omit the concurrent cisplatin while maintaining the outcomes? To explore this, we conducted a phase 2 study using the naval jaw map-based chemoradiotherapy without concurrent suspending. Results show that an excellent 3-year FFS of 88.5% and 40.2% over rate of the grade 3 to 4 accurate toxicity. Building on this, we launched the phase 3 trial and confirming the suspending de-intensification is feasible with PD-1 therapy. Skipping the 3 cycles of the concurrent suspending didn't compromise survival and reduced the vomiting rate to 26%, significantly improved the quality of the patient's life. The phase 2 trial was featured as the cover article in Cancer Cell. Phase 3 trial was selected for an ESCO late-breaking abstract this year and oral presentation, awarded the best of ESCO and published in JAMA. Through a series of landmark studies, our team have played a key role in establishing a new framework for chemoradiotherapy and immunotherapy strategy in PC. Over the past 27 years, the NCCN guideline has issued 6 major updates to its chemoradiotherapy recommendation for NPC. Our evidence supported 5 of them. In the second part, I would like to highlight our efforts to reduce treatment-related toxicity by refining radiotherapy target volume. Traditionally, radiotherapy for NPC has covered the entire neck, regardless the lymph node environment. This broad field often causes long-term side effects, such as the dry mouth, swallowing difficulty, and the hypothyroidism. Through the detailed investigation of the cervical lymph node spread patterns, we found that lower neck involvement is extremely rare when upper neck nodes are involved. Similarly, metastasis in the submandibular and the medial retropharyngeal regions are uncommon. Based on these findings, we proposed a risk-adapted radiotherapy approach that includes the omitting the prophylactic radiation to the submandibular and the medium retropharyngeal regions if uninvolved, and omitting irradiation to the lower neck and the uninvolved sites to help preserve the thyroid function. Through to the large-scale phase 3 trial, we demonstrated that this reduced volume radiotherapy maintained survival outcomes while significantly decreasing toxicity such as xerostomia and hypothyroidism. Additionally, induction chemotherapy achieved a significant tumor shrinkage in over 90% of the patients. This promoted us to reconsider whether radiotherapy should target the tumor volume before or after induction chemotherapy. To answer this, we conducted a prospective multi-center clinical trial. The results show that using post-induction chemotherapy volumes for radiotherapy achieved comparable local regional relapse-free survival compared to the conventional radiotherapy. Moreover, this approach significantly reduced both acute and late radiation toxicity. This body of work was published in the CA and a Cancer Journal for Clinicians as the first randomized control trial in this journal's history, as well as in the BMJ journal and the Lancet Oncology. It has also incorporated into the up-to-date guideline. As part of our commitment to personalized care, we have developed a comprehensive de-escalation strategy that shifts the focus of NPC management from the only prolonging survival to enhancing quality of life of the patients. Our series study had led to 9 publications in leading medical journals. I was as the last corresponding author, for which I served corresponding author, including CA, the New England Journal of Medicine, the Lancet JAMA, the BMJ, and the Nature Medicine and Lancet Oncology. These papers have been widely cited. We have also contributed to the advancing of the global standardization of NPC treatment. As the chair, I led the development of the CISCO and ESCO guideline for NPC and the radiotherapy target volume delegation guideline and the contour atlas, jointly issued by CISCO, CACA, and CISCO, Hygiene, ISCHO, and ASTRO, helping to shape the global clinical practice. As SYSUCC Cancer Center, we have established one of the world's leading radiotherapy centers. Our faculty hosts 17 linear accelerators. In last year, we treat over 18,565 patients with radiotherapy making us the highest volume center globally. And looking ahead, we will continue refine treatment strategy to achieving both longer survival and better quality of life for patients around the world. Thank you for your attention. Thank you.
Okay. Thank you, Professor Ma, for your enlightening speech. Your expertise in the field of NPC research has played a key role in positioning China at the forefront of global advances in APC cancer management. And now I'd like to announce the online viewers has been over 8 million. Congratulations. Now I will ask the Professor Costa to introduce the third speaker. Please, Professor Costa.
Thank you very much. Now I have the privilege to introduce Professor Gerson Lima Silva. He's member of the Brazil Academy of Medicine, member of the Brazilian Academy of Science, full professor of the University Federal do Rio de Janeiro. And beside this outstanding, he's a researcher of the IDOR Institute also. And beside of all this qualification, he's a good writer. And tomorrow he will launch another book and has many skills. Well, he will present phase transition and aggregation of mutant P53, a novel therapeutic target in oncology. Thank you very much, Gerson, for your participation.
Well, thank you very much. I want to thank Professor Wang and Professor Maurício Costa for this honorable invitation. So share my presentation. Let's see. Okay. It's here. Just 1 second. Hope you can see now. So I will change gears a little bit to present some translational medicine work that we have been doing the last 30 years on mutant p53, and I'll try to convince you that as before was mutant p53 was not believed to be druggable for cancer therapy, and we think that with some of the results in the last 10 years from our group and from other groups, it has moved to show that maybe we can target specifically the phase transition aggregation of mutant p53. So in this slide, I just want to show that in the last 10 years, it has been the field of biology has seen a revolution, showing that several proteins, in fact, they need to go into these biomolecular condensates, especially in the nucleus, but also in the cytoplasm, and they function in order to do several many functions in the cell, and but also there are implications, not only functional implications, physiological implications, that you need to have these condensates, for example, for DNA processing, RNA processing, etc. But sometimes the formation of these biomolecular condensates go wrong, and eventually they get into this solid-like state, this phase transition, and that it goes into fibrous. So I don't want to go through all the details, the biophysical details, but that is behind, for example, most of the neurodegenerative disease, such as Alzheimer's, Parkinson, amyotrophic lateral sclerosis, and many others. So we, many years ago, about 25 years ago, start to work on p53, that we know that it's very important, is a tumor suppressor protein that controls the cell cycle, and especially when there is kind of any stress or any kind of damage to the cell, p53 is recruited to fix it, and eventually turning the cell into apoptosis. But we know that when there is a somatic mutation in p53, it stops working, even if you have the other gene working, and this mutation is responsible for more than half of all human cancers, specifically those ones that are with worse prognosis. And we start to work. This protein is a complex protein, has a DNA, is a transcription repressor, and has a DNA binding domain, and the mutations that the somatic mutations involving these forms of cancer are localized exactly in that. So we decided to try to understand, because we know that p53 is considered guardian of the genome, but when something goes wrong, it acts pretty much like a Trojan horse and becomes oncogenic. And we have used in our lab for many years structural biology, biophysical, spectroscope techniques to study the proteins, and particularly have used this methodology to see what happens with a mutant p53. For example, even with wild type p53, if we just increase the temperature, it starts to make aggregates, and the mutant one is more susceptible to make more aggregates with the temperature. And here we use high pressure technique, and particularly this technique is very important because we know that many of the proteins this range are not affected by pressure, and they're showing that the stability of the protein is quite low. And that was about 22 years ago that my student found that it does form these aggregates that are amyloid aggregates or some oligomers, very similar to the ones found, for example, in Alzheimer, in Parkinson's disease, etc. So we propose that would explain, for example, the negative dominance effects of the somatic mutant mutation in p53, and eventually could affect even the one that had not the mutation. So we, in order to test that, we did the first in vitro experiments with recombinant protein. If we look at, if you take the protein, recombinant protein weight long enough at 37 degrees at physiological temperature, the proteins start to aggregate, and we can measure the aggregation by light scattering, by different dyes. But if we add a seed of the mutant form, it accelerates the aggregation and makes, in fact, more increase the amplitude. And we found that these aggregates were again had the by using X-ray crystallography to find that had the fingerprint of an amyloid oligomer or amyloid fibril. But okay, then we went to tumor cell lines and biopsy samples, particularly in triple negative breast tumor cell lines. Here we could use antibodies against amyloids that recognize this amyloid signature, and that one can see that it coincides with the labeling of a p53, and here's the merging showing that they co-localize. And when we have a cell line without the mutation, we have much less aggregates. And in another study, we screened about 9 biopsy samples, and we found that those that had mutation had more aggregated p53. And we and other people have seen that since 2003, the presence of this of a p53, mutant p53 going to this amyloid state, particularly in the nucleus. And we have found, for example, in brain tumor, in glioblastoma, again, we have in red here showing the nucleus, the formation of these aggregates. And then when we have the recombinant protein, we can see that it aggregates much more than the form without the mutation, and that correlates with much lower stability in comparison to the wild type. And in this particular work, we also decided to transfect cells that were they didn't have p53, using p53 labeled with GFP, and we found that indeed they were oligomers. And in another step of the work, we decide, well, are these aggregates related to the formation by molecular condensates? And indeed, we find that both wild type and mutant p53 they can form biomolecular condensates, but the difference is that in vitro, for example, the condensates of mutant p53, that are these kind of droplets, they are very rich. If you use, for example, a laser to do a photolysis by using this technique, fluorescent recovery of photolysis, there is no recovery indicating that it's in a solid state, and the wild type is more in a liquid state. And then again, we transfect cells with using both control wild type p53 and also mutant p53, and here we show that in the nucleus, particularly in the nucleolus, one can see that p53 is completely in a very rigid state. So it has undergone this solid phase transition. So we could revert that a little bit using, for example, polyelectrolyte, heparin, but on the other hand, depending on the condition, RNA that is present in the nucleus can accelerate the conversion into this solid state. And then, before I go to the medicine, we also found that this p53, aggregate p53, we know that the p53 has some paralogous proteins, p63, p73. They form biomolecular condensates, but they don't aggregate, as can be seen in this slide. But when they are put there, we have together mutant p53 together with p63. It converts the p63 or the p73 into these aggregates, showing this prion-like induction of aggregation of p63 and p73, these paralogous proteins. So we observe the same thing, of course, that is very important in the nucleus, in the nucleola, where again, when we transfect both the cells with both p53 and mutant p53 and p63, for example, we observe that again, it goes by looking here in red label, the p63, it gets into this solid state. So we have found why this work is important, but as I mentioned before, p3 was considered for many years undruggable. So maybe we could use aggregation of p3 as a therapeutic targeting. And we know that the mutant p3s are the one that are the worst ones. First, we and others have tried several compounds. One of the approaches to use, for example, some derivatives, resveratrol, that's present in fruits, in different grape juice, in wine, etc. We found that indeed resveratrol can inhibit aggregation in vitro. In cell, we can see that as you increase the concentration, there is there is much less aggregation, both in cell and also in animals, in experimental mice, that when we inject the resveratrol in that large quantity. Another approach that we decide to use are some very important compounds that make some adducts with cysteines on the protein, and particularly this one, Prima 1, that is now for several types of cancer in phase 3. But people didn't know that the mechanism, and in this paper we could show that the main mechanism of anti-cancer action of Prima 1 was by inhibiting the aggregation in vitro, but also in cell. And particularly in this experiment, we could use the antibody that recognize aggregates. And if we don't treat the cells, there are a lot of aggregates in this control. And when we treat we treat it with 100 micromolar, we have disappearance of the aggregates. And we have screened several compounds. I'll just show one of the compounds that we have had success in reducing more than tenfold the amount of in comparison to Prima 1, and is like Prima 1, we can reduce the aggregates as measured both in cell, in vitro, but also in cell again. By doing the immunoprecipitation, you can see that when we treat, there is a reduction, and as shown here on the right, the level of aggregate p3 decrease a lot. And also there is both restoration of the functional state. For example, this candidate medicine restores, inhibits tumor cell migration, and also restore the native-like activity of PIF3. And in these experiments, we treated the mice with intraperitoneally, the mice that were xenographed with triple-negative breast cancer. And again, we found inhibition of tumor growth, both by measuring tumor volume and tumor weight. And again, in the when we looked did the immunohistochemistry, we didn't find any aggregates in the cell. So we proposed that both RCT and PRIMA1 inhibit mutant PIF3 aggregation and activate native-like function, blocking tumor growth. So we more recently, this is outline assay in Nature that showed and cited our paper that inactive clump of PIF3 can be targeted for therapeutic purpose. So in conclusion, I just want to point out the importance of using targeted PIF3 aggregation or phase transition. And we are now going to finish some of this preclinical work and thinking in doing the next steps to do the clinical trials, phase 1 and phase 2. I want just to acknowledge the people that really did the work and the funding agents that supported our work. Again, thank you very much.
Okay. Professor Costa.
Thank you very much, Professor Gerson. I know his work is very important, his target for new cancers, and we hope that it will be, like you said, possible to use drugs in the future, this indication. Now we have the next speaker, Professor Wang. You can introduce, Professor.
Okay, our next speaker is Professor Yongxiang Zhao. Professor Zhao is the Vice President of Guangxi Medical University, Chairman of CACA Biomedicine Committee, and academician of the International Eurasian Academy of Sciences. Today, Professor Zhao will share his presentation topic of Fight Poison with Poison. A single spark can start a prairie fire. Please welcome Professor Zhao.
Yes. Wait a minute. Okay. Good evening, everyone. Many thanks to the organizer and to Professor Daiming Fan. My topic today, poison versus poison. A small spark can start the big fire intravenous for the advanced cancer. This is a new way to fight cancer. Okay, this is we reported the content today. So how do we fix this? We got these three simple ideas and help us get the best drugs to the patients faster and smarter. Now, let's go back to the start. Where did the oncolytic virus research come from? It all started with the two strange stories. In 1896, leukemia patient failed better after coach cold. In 1912, a cervical tumor disappeared after rabies dog bite and rabies shot. That was spark. That's how it began. Then 2006, China said yes to the H101, the first virus based the cancer drug. 2015, the US approved the T-VEC for the melanoma. The too many side effects not strong enough, so the hope faded. 2021, Japanese try again, just only 16 breast cancer patients it got the blow. So the progress is slow, but the fire is still burning. And now it's our turn to carry it forward. Okay, in 2021 and 2022, two NEJM paper reported the phase 1 trials of the oncolytic virus HSV1 named J07 and DNX2401 in glioma, showing that oncolytic viruses are both feasible and promising. And in the 2023 Nature paper report, something surprised. Neutralization antibody to the oncolytic virus might not block the virus therapy. Instead, they could help by boosting the immune response, because a little antibody may be better result. So our work focus on the oncolytic virus, a new virus. These people summarize 4 highlights. First one, it said revolutionize oncolytic virus design, use the hyperacute rejection to enhance the immunity. And the second one is we use the CRISPR monkey liver model to assess in intravenous and NDVGT, which is a new oncolytic virus, its efficacy. The third one is we developed unique oncolytic virus selected to lysis the tumor safely in humans. The fourth, we employed the monkey model that improved the prediction for the clinical translation. So in detail, we solved what we did. The cool challenge. First one, target for the therapeutic therapy. And another one is how to hit the tumor. We make the universal missile. We use the pig antigen called the alpha-gal. The same one that trigger the hyperacute rejection in the organ transplantation. That is the general transplantation. Why? Because most of the tumor hide from the immune system, but the alpha-gal acts as the universal target on the tumor surface, force the immune system to recognize the cancer that solve the immune evasion. So then we armed the virus becomes the smart missiles designed to track hyperacute immune attack right inside the tumor that breaks through immune tolerance. So Newcastle disease virus is a smart virus. It's RNA-based, safe for the people deadly to the cancer. We found the spatial strain after 34 years. That one glues only in the tumor, not in the normal cells. It attacks cancer, not the people, but that's just the start. It wakes up the immune system, the T cells, NK cells, and other immune cells rise. The body fights the back stronger than ever. That's why we use it. They pick up the tumors, multiplies inside, kills from the within, and they call in back up. virus that starts the fight and bring the army. So what the classic sign of the hyperacute rejection? Classic thrombosis in the transplantation organ. Blood flow stops. The organ shut down faster. It's the body's fastest, highest immune attack, tracked by the pre-existing antibody within minutes to several hours. Usually, it is a bad thing we failed in the transplantation because it destroyed the health tissue in no time. But what if we flipped? What if we could aim that same power not at the organ but at the tumor? That's what we did. We used the virus with the transplantation gene, alpha-1/3 gene, that is catalysis to the alpha-gal antigen to trigger the hyperacute rejection inside the cancer. So the sign of the hyperacute rejection are the thrombosis blood stop, tumors die fast, the same reaction, different target. So we did reverse application. We turned the body's strongest rejection response into one of its strongest cancer weapons. Okay. This one, yes. So next, we use the model that tests the oncolytic virus. We called the NDV-GT. Normally we use mice for the most of our drug study, but it worked for a while. But the mice are not people. Too many drugs looked good in the mice, but they failed in human. That's the problem. We need the proof fast. So we built a real tumor model, not mice, in the monkey, close to the human, stronger the result, faster answer, real impact. So here, what we did, after 34 years of the hard work, we found a faster way to test a new drug, not within mice, yes, in the monkey. We built something new, the one gene editing technique that work in the monkey body, guided by the ultrasound. We delivered that through the portal vein straight to the liver. It worked. With this, we created the world's first monkey model of liver cancer with rare spread, just like in human. Why does it matter? Because bad matter means bad drugs. Few fears fast progress from lab to the clinic to the patient. The tumor spread was clear in the specimen. You can see one tumor lesions become many. You can say so. There are more. The tumor didn't just grow; they spread. You can say to the lung, to the liver, to the spleen, and the lymphocyte. The rare metastasis. The model was rare. The result come fast. Okay, we got the shot 2. We are moving forward. We conduct a phase 2-3 clinical trial is now underway, testing our hypersensitive oncolytic virus NDV-GT in the patient with the advanced cancer. It's not just safe, it's showing sign of the real-time control. The real immune response from the label discovery. We didn't stop at just one way. We found many ways to give the virus through the vein, into the chest, into the belly, and the more. Whatever it takes to reach the cancer, we are making it happen. So we run phase 2 and phase 3 trials.
we enrolled patients with the 14 types of the advanced cancer, including lung cancer, the liver cancer, and the esophageal cancers, ovarian cancers, and so on. We tested them. So we run phase 3 and 3, we got the result. What did we say? You can say 5.7% the CR, 31% PR, 54% SD, 1.2% PD got worse. That's over 90% with DCR. And more than 80% live longer than 1 year. We are not just testing, we are making difference. Okay, the representative case is one, advanced liver cancer spread to the both lung. 1 month after treatment, the liver tumor were almost gone. And the second one is advanced ovarian cancer, spread slowly belly and the liver. After 3 months, over 90% of the tumors were gone too. And this one is advanced central lung cancer. After 1 month, 70 gone. And this one is ovarian cancer with the fluid in the both pleural cavities. Left side is 67 centimeter dips. Right side is 5.60 centimeter. After 2 weeks, the fluid disappeared or gone. So unlike the other oncological virus, ours works on many types of the cancer. It is given by the intravenous injection, simple, safe, no harm to the health cells. It could be used in any, maybe clinical. So, okay. So let's take away. We title is points was points. Original title is fight the points with the points. Okay. So the features is a new virus, new process, new standard ordered by the intravenous injection. So works fast, no toxicity, and affordable. Okay. So we summarize the highlights. So okay. So okay. And the paper published at the same time, the Nature run the front page feature alongside of the cell paper, a deep dive, big spotlight. They comment one of the review expert from the Canada. He said, "I'm very hopeful for this oncological virus." So the shortcut way we are doing NDA probe green channel for the NDA. For example, Japanese approved the Diakashi Sankyo's virus after treating just 16 patients, small trial, bigger approval, and China spin up 20 to 30 rare cases. That's enough, maybe fast track conditional probe. Good news for us. Okay. So summarize we did this kind of the job for the NDV GT, the new oncological virus, built on the monkey model, and this model is one of the China top 10 medical biotechnology advances in 2021, and this one is the NDV GT honored as the China top 10 biotech breakthrough. And the same one is Wang, our country 2024 Outstanding Drug Innovation Award. Okay. And we, under the CACA guideline, we were worked on this drug since 2015. Our real world data directly contributed to the CACA guideline. Real patient, real insights. Now we are leading to the NDV clinical guide coming soon. So that's why we're moving forward fast And with the confidence, we believe the drug is ready to insurance. For the patient, less pain, more time, real hope. Okay, so the journey has begun. It won't be easy, but we got there for the health, for hope, for all. So thank you for your time. That's all. Thank you for your time.
Okay, thank you, Professor Zhao, for your remarkable presentation. Your research provides a valuable perspective on optimizing treatment strategies on the nanocellular level. Thank you again. We'll ask Professor Costa to introduce the last speaker. Professor Costa, please.
Thank you very much, Professor Wang. I have now the honor to introduce Professor Leandro Iwamoto. He's a professor in the University of São Paulo. He works with rehabilitation, physiatry, and has a very good experience with the Oriental medicine. And I asked him to present his experience about these transcultural aspects of the Oriental medicine in Brazil. That's a country with other kind of culture, more European, African, in the nation. Well, Leandro is also a member of our Young Physician Leader programs. That's a program that we have 40 young doctors, outstanding doctors from Brazil. This program is connected to Inter-Academy Partnership Program of the Young Physician Leaders International Program. And it's a very active program. And for the last year and this year, we had the support of CACA to sponsor the trip of one of these young physician leaders to China for the CACA Congress. And I really would like to thank Professor Daiming and Professor Wang for this opportunity for these young doctors. That's a really outstanding opportunity, and they really appreciate very much. And we thank you again for all the support. Professor Leandro, you have the time for your presentation. Thank you very much to come.
Thank you very much. Thank you very much, Professor Maurício Magalhães, Professor Wang. I will share my presentation now. Can you see the presentation? Okay, now I'll start. Good morning and good evening. It's an honor to be here at China-Brazil Anti-Cancer Summit. Today, I will be discussing the fascinating journey of traditional Chinese medicine, as called as TCM in Brazil, from its early roots to its current integration into our healthcare system and the vital scientific dialogue between our two nations. So TCM is a comprehensive medical system with a history spanning of thousands of years. Its main pillars include acupuncture, which is the insertion of fine needles into specific points to rebalance the body's energy flow, or qi, and phytotherapy, which is herbal medicine, and the use of plants and herbal formulas to treat disease and promote health, and also the holistic framework, viewing the body as an interconnected system of mind, body, and spirit, where balance is essential for health. And the World Health Organization has recognized acupuncture as an effective treatment for numerous conditions since 1979, a list that continues to expand. And the aim of this talk is to trace Brazil's unique journey in adopting and integrating TCM, highlight its current impact on our healthcare landscape, and underscore the importance of ongoing Sino-Brazilian collaboration in advancing this field, particularly in oncology also. So we have our early roots here in Brazil, and we need to see that the first practitioners come to Brazil, and the seeds of Oriental medicine in Brazil was planted by Chinese immigrants who arrived as early as 1810, bringing with them rudimentary knowledge of their traditional practices, and also Japanese immigrants in 1908 also introduced their style of acupuncture, thought it was initially confined to their communities. And for decades, these practices remained largely within immigrant communities offered in private clinics. However, a gradual curiosity began to build within the broader Brazilian public. And in the 1970s, marked as a shift with a growing interest in scientific circles, setting the stage for wider acceptance. And here we see a turning point, which was Nixon's China visit. President Richard Nixon's historic visit to China in 1972 captured global attention. And during this trip, the New York Times' James Reston underwent an emergency appendectomy, and his postoperative pain was successfully treated with acupuncture. And his subsequent article, Now About My Operation in Peking, published on the front page, became a catalyst. And this widely publicized account is credited with sparking significant interest in acupuncture across the Western world, including Brazil. And after this, in 1988, a significant step was taken with a public health decree authorizing the use of acupuncture even before the establishment of Brazil's unified health system. We call this SUS. And in 1992, the Federal Council of Medicine, the CFM, recognizes acupuncture as a medical act. And in 1995, the CFM elevated acupuncture to a medical specialty for pain management, a landmark decision that solidified its place within conventional medicine. And this was growing of academic training, and also the first practical courses and certifications began to appear in the 1990s, responding to the growing of demand for qualified practitioners. And 2002 onward, universities started offering acupuncture as an elective for undergraduate students in various health fields. Today, Brazil boasts dozens of postgraduate programs and official medical residencies in acupuncture, ensuring a high standard of training of our physicians. And Brazil is one of the most important countries outside of China with a medical residency program in acupuncture. And the Brazilian College of Medical Acupuncture was founded to standardize the practice of medical acupuncture, foster highlight quality research, and ensure ethical and competent practice among physicians. Their key activities are providing a platform for the exchange of knowledge and the latest research findings, disseminating Brazilian research in acupuncture to a national and international audience, and also actively collaborating with Chinese university and World Health Organizations to align with global standards and advance in the field. And here we can see our milestones timeline in our university, which began in 1973 with Rio Doraco electroacupuncture with Dr. Sachiko Tomikawa. And after this, we come to 1989, launching of Chinese classical acupuncture in outpatient clinic by Dr. Vutu Singh, who is still today coordinating the course. And until 2015, we have medical residency, shockwave therapy, phytotherapy specialization. So we had the establishment of medical residency program and the introduction of these new specializations in pain management. And here we can see the evolution of the introduction of acupuncture in our undergraduate course. So, acupuncture is now a widely accepted therapy for a range of conditions in Brazil, as pain syndromes, for example, chronic back pain, arthritis, headaches, and musculoskeletal pain are the most common applications. Also, we have the neurological rehabilitation, assisting in the recovery of stroke patients and managing neuropathy, mental health management, effectively used to treat anxiety, depression, and insomnia. And also we have integrating oncology and palliative care, which is a growing and crucial area of application. Pilot programs are demonstrating its value in managing the side effects of cancer treatments such as nausea, fatigue, and pain, significantly improving the quality of life of our patients. And here we can see the phytotherapy in Brazil. The Brazil's National Health Surveillance Agency, the Anvisa, regulates herbal medicines through a rigorous process. This includes the publication of herbal monographs that detail the approved uses, dosage and quality control standards. And also we have many herbs from the traditional Chinese medicine and traditional Chinese materia medica are now used in Brazil, including Australogallus, ginkgo biloba, and Rehmannia. And also there's a growing body of research in Brazil focusing on the efficacy and safety of these herbs, with a strong emphasis on quality control protocols to ensure the purity and potency of phytotherapy products. And here we have the development of other courses at the University of São Paulo Medical School, and USP is at the forefront of research into image-guided acupuncture using ultrasound and MRI to enhance the precision and effectiveness of needle placement. Shockwave therapy, this modern technology, is being used as adjunct to acupuncture for musculoskeletal pain, demonstrating a synergistic effect that promotes tissue healing and provides pain relief. And also we work with interdisciplinary teams, which is a key to success with the collaboration between anesthesiologists, radiologists, and TCM practitioners, creating a truly integrative approach to patient care. And also, we have the course for undergraduate with undergraduate elective with the introduction of acupuncture. This course provides medical students with a foundational understanding of principles and applications of acupuncture early in their careers. Also, we have acupuncture in orofacial pain, which is a specialized program that highlights the efficacy of acupuncture in a specific and often difficult to treat area of pain. And also we have the training to the next generations of researchers in how to design and conduct high quality clinical trials on acupuncture, building a robust evidence base. So the ultimate goal is not to replace conventional medicine, but to practice integrative medicine, a patient-centered approach that combines both the best of both Eastern and Western practices. And our key principles are evidence-based protocols using treatments that are supported by scientific evidence, shared decision-making involving the patient as an active participant in their own care. And also we have some challenges to overcome, which are the standardization, ensuring consistent quality and practice across different settings, securing resources for research and clinical programs, and also fostering a deeper understanding and respect between practitioners of different medical traditions. And we believe that the partnership between Brazil and China is crucial for the future of integrative medicine. For example, we have a roadmap for collaboration in telemedicine using technology to bridge geographical distance for consultations and education, blended curricula developing joint educational programs that combine the strengths of both countries' medical training, and also mutual accreditation in the future, establishing recognized standards for practitioners in both nations. And also we work on joint research initiatives as co-authored publications and multi-center trials, working together on high-impact research that can influence global practice, and also research partnerships, creating joint laboratories and exchange fellowships for students and researchers to foster a deep and lasting collaborations. So TCM is firmly established here in Brazil. We have particularly acupuncture and phytotherapy is no longer on the fringes of Brazilian healthcare. It is an established and growing field. We have USP, the University of São Paulo, as a model. The work being done at institutions like the University of São Paulo serves as a powerful model for how successfully integrate TCM into a modern research-oriented medical system. And also the path forward is clear. We must continue to deepen the scientific dialogue and research partnerships between Brazil and China. By working together, we can unlock the full potential of integrative medicine to improve patient outcomes, especially in the challenge field for oncology. So thank you for your attention. I would be happy to answer any questions, and here are my contact information. Thank you very much.
Okay. Professor Costa.
Thank you very much, Professor Leandro. It was a really nice presentation. I think you fulfill the goals of your presentation, showing how we are going in this integration of the Oriental medicine in Brazil. And I think this could, as you said, a good step for the future. I really would like to congratulate all the speakers. I think it was an amazing meeting. I would suggest, Professor Fan and Professor Wang, that we do this meeting twice a year at least. I think considering the high quality and the possible of integration, I think we should make it more often, and hopefully, we can do it presential as we did last year in Rio de Janeiro. But I would like to make two I would like to make two comments.
I completely agree with you.
Thank you.
That's a good idea.
Very nice.
Yeah.
Yes, as I have received all this, and the group of the academy is really very happy with this opportunity, and we will go forward in this direction. I'd like to make two comments before to open. The first, for Professor Ma, I was really impressed with your center, how the quality that you are doing in research and the quality, this nasopharyngeal, and this is a very serious problem also in Brazil. What I'd like to ask you, this high incidence, as we said in the first, we have seen in the first presentation, Professor Stevens, this, that HPV is related to cervical, to anal cancer, but as I know, also the nasopharyngeal cancer. I would like to ask you if in your experience in China, you are getting more and more cases of nasopharyngeal related to HPV, or tobacco is the main risk factor? I'd like to ask you this aspect to you, Professor.
Okay, thank you. Thank you, your question. NPC NPC is endemic in South China. And the main point is strongly associated with genetic background. Also with the EB virus, not HPV virus, as EB virus. So in South China, in our patients, about 30% have the family cancer history, and 10% they have NPC history. So as the wine and the smoking will be elevated the EB virus activity. So it's a positive to simulating the transformation from the epithelial cell to cancer cell. Thank you.
Thank you. And another question, another comment. It's about
Dr. Costa, I'm a gastroenterologist. So just like you say, that HPV is very correlated with onset of cervical cancer, but also in the upper gastroenterologic GI. So it's also the esophageal cancer and also stomach cancer. It's about 15% of it's related. That means related to the nasopharyngeal cancer. We don't know exactly. That is according to Dr. Ma. So.
Thank you. I ask you this because I think that this research that Professor Stevens is doing, probably you have there is a possibility to use it in other locations, like other areas of the body, like nasopharyngeal or gastrointestinal. this opportunity to have this early diagnosis with the ctDNA. I think it is a very important tool. And another comment that I would like to say is about the virus, the poison. That's in Brazil. We had a few years ago, we had a big epidemic of Zika virus. I don't know if you have heard about this. We have, for some reason, many cases. That was a tragic problem. Any newborn was very seriously damaged by the virus. And as I know, there are some groups that are studying this virus because of this neurotropism of the Zika virus with to use to combine the treatment of neurological tumors, brain tumors. I don't know if Professor Gerso has some experience with this, have you heard about this? I think you are in IDOR. I think they are doing some research like this. And then I would like to ask you if you had the opportunity to use this kind of virus in your research. And if Professor Gerson could make some comments about this.
Yes, thank you very much. Excuse me, what kind of the cancer you mentioned? I didn't not clear. Beg your pardon.
It's for neurological, the brain tumors, because the virus, they have a tropism for neurological. Gerson could explain, Gerson.
Yeah. If you allow me very quickly, there are two groups working on using the Zika virus because it has this preference to go to neuron system. And Professor Mariana Zatz in São Paulo, University of São Paulo, I think she has one or two papers, and also Professor Vivaldo at the Instituto do Cérebro, Paulo Niemeyer Brain Institute, also have done some work. And basically the main mechanism is that because he's this tropism to neurocells, and they both groups have used the glioblastoma. In our group, we have started to do that, and we didn't publish, but it does in at least in tumoral cell lines, we could also observe the oncolytic effect, very similar to what Professor Zhao has shown with other oncolytic virus. So that might be an opportunity, maybe an opportunity to collaboration. Yeah.
Yes.
Okay. One
Thank you.
question.
And congratulations. And Professor Wang, please.
Yes.
For your closing
one
remarks.
question to Lumoto. So you gave a very good presentation on the integrative of Oriental medicine, and you have gave the map that development of acupuncture. So do you when you doing the acupuncture, do you combine with Chinese herb or herbs with acupuncture treatment? And what's the outcome for the acupuncture comparing with patients with acupuncture and without acupuncture? Do you have the comparison? Thank you.
Thank you very much, Professor Wang, for the question. Yes, I do the acupuncture combined with Chinese herbal medicine, and we have a great outcome. It is better the combination with the two techniques to treat the patient's symptoms like nausea, like pain, and also vomiting. We can treat the symptoms with the combination of these two techniques. And also the acupuncture is more effective with to the pain treatment of patients, And also the electroacupuncture is more effective than the acupuncture isolated. The acupuncture technique is similarly to the dry needling technique we use in physical medicine rehabilitation to treat some trigger points in myofascial pain syndrome. And also, the acupuncture has more specifically some specific techniques like scalp acupuncture and also another kind of specific acupuncture points to treat oncology patients, for example. And we have a better result combining the both of therapy and also associating with another treatments. And it's not isolated treatment, but the combination of both is better.
Yeah.
Thank you. Okay, thank you. Any questions? So I think, Professor Costa, I think the time is up. Yes, 5 minutes left. So I would like to give the closing remarks. Thank you, for Professor Costa, for your great moderation. The speakers' conversations were not only engaging but also productive, advancing our collective knowledge and fostering deeper collaboration in the vital field of oncology. As we bring this summit to a close, I'm filled with a sense of gratitude and optimism. It's been a great journey of learning and sharing, where there's a bit of a reluctance to conclude our time together. I'm excited about the future paths that will emerge from today's discussions. Now, I would like to share with you the exciting news that the online viewers have reached 17 million. Congratulations. My heartfelt appreciation goes out to all speakers, organizers, and participants. Once again, thank you all for your dedication and contributions. At the last, I would like to wish everyone good health and good luck. We are looking forward to meeting you all at the next International Summit. Take care and goodbye. Thank you.
Goodbye.